Hello, my name's Elizabeth Ortiz, and I'm a nurse in the midst of becoming an adult and gerontologic nurse practitioner and completing my doctorate of nursing practice. I've worked for 34 years as a nurse, and I have a passion for working with both underserved and desperate populations. This has led me to working with several organizations that travel both within the United States and in other countries to offer disaster relief, as well as to countries where poverty and lack of access have had a devastating effect on the health of the people there. This work, along with trainings that I've done through the Red Cross, FEMA, and just through textbook and journal readings, increased my awareness that there's a dearth of training for nurses that is specific to disaster response nursing. Therefore, for my nurse practitioner project, I have created this training with the desire of alleviating some of the anxiety that nurses feel about traveling with disaster relief organizations, to answer questions about the nurse's role in disaster relief, and to review disaster relief and response in general. So to begin with, it's important to understand and define what is a disaster. The Federal Emergency Management Agency, or FEMA, defines disaster as the occurrence of a natural catastrophe, technological accident, or human-caused event that has resulted in severe property damage, deaths, and/or multiple injuries. The Red Cross defines disaster as a disruption to a community significant enough to surpass the capacity of the local resources to cope, and it can be natural, man-made, or technological. Within the United States, FEMA is in charge of federal disaster and disaster relief, and they've created levels to define the extent of disasters within the United States. And the level of disaster determines the assistance that can be received from non-local agencies. So we're going to review them now. A level 3 disaster is a such thing as a residential fire or an overturned truck that's carrying and spilling out hazardous chemicals, or storm damage that's occurred from wind or hail that has damaged homes. In these instances, the local fire and rescue can contain and handle the incident, and occasionally a regional help is called in, possibly from the next town over, and helps them to deal with it. There's very little, if any, involvement from the national government or from FEMA. In a level 2 disaster, it's a more moderate, more extensive level of disaster. So this may be something like localized flooding of homes and businesses from a storm surge, a tornado with moderate amounts of localized loss of homes and businesses, and possibly lives. At this level, local and regional agencies are strained to contain the problem and will sometimes involve state agencies as well. FEMA may oversee this disaster, but their involvement remains low. In a level 1 disaster, this is a disaster of such magnitude that all local, regional, and even state, and possibly national agencies are overwhelmed. There is extensive loss of life and/or property, massive levels of damage, and possibly it's a multi-state impact. This requires the highest level of federal assistance for response and recovery, and even this is overwhelmed. We experienced this just a few years ago as COVID-19 ravaged our country and our world, and all of the relief organizations were overwhelmed in trying to respond. In this instance, FEMA would definitely be completely involved. The national government would also be involved in this response. So in addition to the levels of disaster, there are stages within disaster and within disaster relief. FEMA lists 5 stages of disasters, and they call them mission areas, and other sources often list 3. I have combined the first three of FEMA's missions here so that we have the 3 stages of disaster. So the first stage is the pre-impact or preparedness stage. And in this stage, we have prevention, where we're trying to prevent or avoid any acts of terrorism or any harm that might occur from storms, from major disasters like forest fires and those types of things. So this is all of the planning and the meetings that occur where the disaster relief organizations get together and try to think of things that might occur and how they can avoid those occurrences. This is a time when then these agencies are working to protect citizens and visitors against possible threats and hazards. This also involves mitigation, and mitigation just means reducing the effects or the loss of life and property from any future disasters. We know that disasters will occur. In fact, we know that over the past decades, the number of natural and man-made disasters has been increasing. So what we can do is plan for them in the best way possible and plan to reduce their effects as much as possible. So this involves analyzing the risks, having a plan in place, having agencies prepared, improving building codes so that they hold up to earthquakes and storms more readily, and having response organizations ready and making sure that they each one know their role and they're ready to mobilize quickly and in coordination with other organizations. The preparedness of a team means that they are ready to mobilize as soon as they're called upon by disaster headquarters. A team should never just deploy without orders or coordination into a disaster without getting their orders in place. Each organization should know its specific role, and each team member should be aware of their role within the disaster as well. The next phase in disaster is response, and this phase is when there is rescue of lives. This is when we're pulling people out of rubble. This is when people are being taken into the disaster triage tents and getting their wounds taken care of and being transported to hospitals and other facilities for shelter and medications and treatments. It's providing relief for the injuries that they have. The faster this response is, the better the outcome because it minimizes the number of casualties. But first, there has to be, we have to ensure that there is safety for the people who are going in as responders. And then the final phase is post-impact or recovery. And in this phase, this is when reconstruction and rehabilitation occurs. This is the time when the hope of rescuing lives has dwindled and the phase turns to recovery. We are recovering bodies rather than pulling out injured people, recovering homes, beginning the long process of rebuilding homes, rebuilding businesses, communities, and lives. In the beginning of this phase, there's often excitement because the people can finally move on. They feel some restoration of their hope for the future. But in time, that often gives way to the next stage of grief, where they feel anger over their losses and disappointment in their new start. Eventually, with assistance and with emotional help, the people can find acceptance and embrace their new life. So at this point, you may be asking, okay, so where do I fit in? Nurses fit into all of this. The answer is simply that, everywhere. In disaster preparedness and disaster training drills, in teaching disaster response during nursing schools, in incident command centers, at the scene of recovery, assisting with triage, opening and maintaining and managing shelters, organizing blood drives for those people who are injured, at the treatment scene with assessment, with administering medications, giving IV therapy, applying dressings, teaching, and giving emotional support. In local hospitals, assisting with the surge of patients that are admitted from the scene. And on it goes. Nursing outreach is unending in the local community and around the world. So then we need to define what is disaster nursing. Disaster nursing is nurses working within a disaster response organization in response to a crisis that has surpassed the ability of the local healthcare agencies. Disaster nursing occurs at all levels of disaster response, in planning for future disasters, in emergency response, in operating shelters, and in staffing medical facilities. Disaster nursing requires training to be knowledgeable, skilled, and able to perform assessments in difficult and often dangerous conditions, often for very long periods of time and with limited resources. At the scene of a disaster, nurses will assess patients and make decisions regarding whether they receive further treatment, what types of treatment they receive, and the nurses will deliver the treatment themselves. In a hospital setting, a nurse may triage the patient and may apply the treatments, but at some point, the patient is going to have to be seen by the primary care provider prior to discharge. This is not always true in a disaster setting. The nurse may be the only person to see the victim and the only person to treat them or to decide that they're okay to leave the area without treatment. This is why disaster response training is imperative. You will hear this again, but the picture here has a statement. The overall goal of disaster nursing is to achieve the best possible level of health for the people and community involved in the disaster, where professional supplies, equipment, physical facilities, and utilities are limited or not available. And this is important because the evidence has clearly shown that teams who deploy with disaster response training are more effective than those who deploy with nurses who have no disaster training. The desire to help and do good is not enough to make a team effective. Just as nurses are trained for other specialties and skills, ER nursing, ICU nursing, pediatrics, chest tubes, even hand washing, nurses need to be trained to be competent in disaster response. Another question that comes up often with nurses and nurse practitioners is, can I be sued for care that I administer during disaster response? And some nurses have actually refused the opportunity to work with disaster relief because they're afraid of being sued. But the answer here is no. As long as the nurse is working in a volunteer, meaning uncompensated capacity, the nurse is covered by the Good Samaritan law. When a healthcare provider renders, in good faith, emergency care or assistance at the scene of an emergency or accident, no liability may be imposed for any civil damages arising from acts or omissions in rendering such emergency care. This should remove any question in the mind of a nurse who is afraid to go in the event that she may be sued or he may be sued. This Good Samaritan law also includes any emergency care given at the scene to a minor when the parents are not present or are otherwise not capable of giving consent. There is no protection in the law against a nurse who commits gross negligence or wanton acts or omissions. Rapid deployment. When a disaster occurs, members of a disaster relief organization generally will receive a text message or an email that simply states that there has been a disaster which requires the response of the medical team. And the question will be, are you able to deploy within the next 24 to 48 hours? Please respond yes, no, or maybe. And then there may be a second question. Are you able to respond within 2 weeks? Are you able to respond within a month? And this is because teams often work within a cascading fashion where an agency will send the first team and that team will be there for a week to 2 weeks. And then a second team will deploy from that agency. And the team that's leaving will brief the oncoming team at the site before they leave the site. Prior to going, some other things that are good to know is if deploying to an area that has been through a disaster, often there are animals that are running around that are hungry, that are afraid, and that may be dangerous. So it is always a good idea to have your rabies vaccination prior to going into those areas, especially if rabies is endemic there or if there's a risk of animal bites. Be sure to check the vaccination recommendations for the area to which you're traveling. Some countries have high levels of certain diseases, and there are vaccinations for those diseases that are really important to get before you travel. Be sure to have several weeks of your medication with you. You often will not be able to get the medication once you arrive at that disaster site. Even if it's within the United States, the medications that are taken to the site are for the patients that we're treating. So it's a good idea to take several weeks of the medication along. If water supply has been contaminated, or if there's any reason to suspect that the water in that area is not potable, it's a good idea to take a water bottle that has a filtered straw that states that it makes any water potable. It's a good idea to take sunscreen. Even in winter, it's a good idea to take sunscreen because you're likely to be outside for hours and hours at a time. It's a good idea to take a large hat, a floppy hat, or a ball cap even. It's a good idea to have an extra battery charger for your phone and any other electronics. Antibacterial wipes are a great thing to have along. Gel, gloves, if you want to take your own box of gloves, that's always a helpful thing. And a basic clinical kit, so your stethoscope, your blood pressure cuff, pulse oximeter, pen, paper, the things that you would take to go to work in a hospital setting. Scissors and Kelly clamps are also very helpful at times. It's also great to have along with you electrolyte single packs that you can get, Gatorade packs or just E-Lite packs. To put into your drink bottle, and small, rich, individually wrapped protein snacks are another staple. Other things that you might want to pack, and a lot of these are just obvious things, but when you're getting ready to deploy for the first time, if you have this list or another list like it to just kind of eyeball and make sure that you didn't forget anything, this is a list of things you'd like to take along. Often you're going to have just one small bag because most of the room on the plane or in the vehicle that you're riding in will be reserved for medical supplies. You want to pack lightly. Remember, there's not room for extras. You may be sleeping in a tent. You don't know what your facilities will be once you get there. A few notes. It's always good to take along at least a disposable rain jacket. If it's winter, you're going to want a heavier coat as well. You may have long hours outside, so don't forget that sunscreen and hat. A quick drying towel is a good idea, especially if you end up sleeping in tents and have limited facilities. Spending money. You should not need much spending money, but you may need some at some point. You might want to make a run to a store once things are settled enough that you can do that. to get supplies. You shouldn't take much because sometimes you may forget and leave your bag unattended, and unfortunately it's a desperate time for people in the area, and so they may be trying to find food for their family and may need money for that. Light sticks are a great way to light paths so you can find your group, and they're helpful when there's no electricity. Your water bottle, as I said before, should be equipped with a filtering straw, and you can get those on Amazon or at camping stores. If there's no electricity, a battery station or extra cell battery, they do make solar batteries now that you can use for cell phones, and those are a great help. Flashlight, bleach. I have bleach on here, and the reason for that is that sometimes the water is dirty to the point that you need to use bleach to be able to use the water for anything. Sunglasses, antibacterial soap. Dial, for instance, has antibacterial soap that you can use for bathing. Sometimes the people are going to have infestations, and so I always feel like if I use a soap and possibly shampoo that has some antibacterial properties, that I am less likely to get that. I don't know if there's any real scientific background on that, but it makes me feel better. Also, last thing, and I forgot to put this on here, but a roll of toilet paper is a great thing to pack in case that runs low. So let's get to the meat of this. While nurses, as I said, are involved in every stage of disaster planning, the planning, response, and recovery, the focus of this training is going to be on the response phase. So over the next slides, we're going to just go through some of the expectations for each phase of disaster response. Upon arrival at the disaster site, each person should be prepared to quickly stow their belongings, use the facilities, and then participate in a briefing from either the head of the disaster relief organization that your team is relieving, or an authority at the scene, or your own leader at the disaster site. Generally, following the disaster, teams, as I said, work in succession, so one team will brief the next team as they come and go. The team leader, along with local authorities and other organizations on site, will decide where is the best area for you to set up your camp, set up your triage, and your treatment areas. Each nurse will then do a rapid risk assessment of that area and an analysis of the area, determine what the strengths and weaknesses of the area are for setting up a disaster triage, and figure out ways around any weaknesses that they see. While nurses are dedicated to the patients that they serve, first they have to look at their own safety. They have to make sure that the area is safe for them to be in before they put themselves at risk. In the United States, the triage process is a little different often than it is in other countries where disasters are more frequent due to tropical storms, floods, earthquakes, etc. In those areas, often when you triage patients, you treat them and then you're going to send them right back out to where they'll be living for sometimes weeks and months, and sometimes even years, under plastic sheeting or some other type of makeshift temporary shelter that they've developed. In the United States, the temporary shelter is generally found in hotels or schools or stadiums, sometimes hospitals, or other, they'll go to other family members. And groups such as Red Cross will assist in sheltering those victims. In other countries, you're going to often send them right back out after you've treated their wounds. Triage will be discussed thoroughly in the next few slides. The goal in the field is always to help as many patients as possible. Resources and personnel are much more limited than they are in a hospital or a small-scale disaster situation. So decisions of who to treat must be based on the triage process and nothing else. Ambulatory patients are low priority. Prior to deployment or at the briefing, each nurse will be given a pre-assigned duty. This position will be held for the entire deployment unless it's otherwise instructed. Nurses will be working in either the triage area, the treatment area, monitoring patients in a holding area, or they may even be working as runners or helping in a pharmacy area, depending on the need at the time. So finally, we're going to, at the end, review personal protective equipment and the decontamination process. So next, let's look at our goals. What are our goals as we go to a disaster site? It's very different from it would be working in-house at a hospital or in an emergency room or a care home. While many of the same skills are utilized, the thought process has to change. Many disaster victims are going to come to the triage area and be seen and treated by nurses and then released to shelter without ever seeing a primary care provider or doctor. Nurses provide first aid, advanced clinical treatment, life-saving medications, assess and triage victims, are responsible for the allocation of scarce resources. They monitor both physical and mental health needs of victims. Nurses also are responsible for isolating any individuals that are thought they might be contaminated with communicable conditions. The level of critical thought and nursing autonomy is higher at a disaster response site because you as the nurse may be the only responder that sees that patient. It's imperative that you're equipped to quickly assess, triage, and treat the patient so that you can move to the next patient and the next and continue to do the same. It's also essential that you're trained in basic first aid. Treating a wound or a bite in the field is very different than in the hospital where you have many more supplies at hand. The best way to accomplish comfort in this is to attend a full day training in disaster response that includes simulation exercises. This course will help you to prepare for the role, but you might want to consider continuing your education further in disaster response. Victims that are brought to the triage area may arrive on site on a stretcher. They may be walked in by a volunteer that's in the area, or a family member or someone who's there may be helping them to struggle into the area. Regardless of how they arrive, the process is the same. Each patient will be triaged and then moved accordingly. So I've used the word triage repeatedly, and we are used to triage in the hospital, but triage, again, is a little different at the site of a disaster. The goal here is the greatest good for the greatest number of people. So we have to allocate those very scarce resources. And this means that some people that we in the hospital would consider our very first patients are going to be our very last patients. The scene here on this slide shows one possible layout of a triage scene. Because it appears to be within an urban area, there are emergency vehicles on the scene for transport. When a scene is at a larger disaster, the transport may be a helicopter or buses taking people out, or in some cases, transport may not yet be established. There is also a triage tag here on the left, and it's an example of ones that are used by emergency responders at all disaster scenes. The tag will remain with the patient while they're at the scene, and the end will be pulled off to designate what level the patient is. For example, if the patient is a red tag, then the yellow and green will be removed, and that patient will have just the red and up on their tag. You can see that on this tag there are spaces for determining respirations, perfusion, and mental status. And then there is a notation about whether the patient is oriented, disoriented, or unconscious. If there are visible major injuries, and then a time with pulse, blood pressure, and respirations. And we'll talk more about each of these things as it relates to triage, but note that there are 3 spots here for time, pulse, and blood pressure and respirations. And so that is a reminder that we're not just going to triage the patients and then leave them. As long as they're in our care, we will continue to round on them and check on them. So here again on the right, you see another use of the yellow and red triage areas. Right here is the yellow and here is the red. As soon as transport comes to the people with a red triage will be transported to an acute care facility or an ED. And at the immediate scene of a disaster, patients are triaged with the goal, again, of getting the greatest number of victims to safety. The most commonly used method for triage at a disaster site is called START, which stands for Simple Triage and Rapid Treatment. This is not what we use in the hospital. It is not those patients who are in the worst condition or dying who are first. And this can be a difficult distinction for nurses and medical personnel. This is what's known as the reverse triage method. First, we take anyone who is walking and or has only minor injuries, and we'll say, follow me, and we'll lead them to a green holding area. And that is another secondary triage or a holding area. The patients in this area will be seen and they will be given a green tag that will be filled out appropriately for them. Next, we'll see the patients who need more urgent care. As usual, we begin with airway and breathing. If a victim is not breathing, we reposition the airway and see if it elicits spontaneous respirations. If so, the patient is red tagged and they require immediate transport to an emergency department. If respirations are present and they are greater than 30 breaths per minute, they need transport for emergent care as they are likely compensating for bleeding. If adjusting the airway does not produce breaths, they are tagged deceased and the responder moves on to the next patient. We do not try to initiate CPR. If respiratory rate is less than 30 breaths per minute, we check to see if the patient is perfusing. Is there a radial pulse? Is there capillary refill, if it's possible to check that? If there is no radial pulse, but there are other pulses present, or if capillary refill is greater than or equal to 2, then that patient will get a reg tag and will have immediate transport. In hypovolemia, the radial pulse will be lost before the femoral and carotid. If the radial pulse is normal and the capillary refill is brisk, then check mentation. Is mentation normal? Can they follow commands? If so, give them a yellow tag and move them to the yellow area and move on. They can be delayed for transport and treatment. If the patient does not have any problems with their radial pulse, it's normal, and their capillary refill is brisk, but they're not responding appropriately to commands, then suspect that they may have a traumatic brain injury. Red tag them and send them for immediate transport. If there is no pulse, then the patient is deceased. We put a black tag on and we move to the next patient. This is a further breakdown of just a few things that you might see at the scene of a disaster and the appropriate classification for each of them. So, green tags are things such as, but not limited to, no injuries or sprains or closed fractures or a mild head wound or a mild burn. These people will be first moved from any unstable situation. They are called the walking wounded. Each of these people will be placed in the green area, but they can walk around if they so choose, as long as they keep their tag with them. The next group, the red group, is the most wounded, the most seriously wounded group. These might have inhalation burns, they might have arterial bleeds, severe head trauma, they might have a pneumothorax or hemothorax, they may be in shock, or have a number of very serious injuries that are visible. Immediate transport to the hospital is necessary. These are the most severe injuries, but they are still viable, meaning that there is every expectation that they will live given the proper treatment. The next group is the yellow group. These people might have compound fractures. They might have facial trauma, but with a clear airway. They may have some minor burns. They may have, or they may even have more extensive burns as long as they're not interfering with airway, and those with injuries to their eye. The transport can be delayed for a short period, and we continue to reassess them to see if their level changes. The black tags are those people who are either deceased or who've had a cardiac arrest, who have absent cranial nerve function, and this doesn't mean that you're going to run down the full cranial nerve assessment, but if you notice that they have any sign that there is a traumatic brain injury that is extensive enough that they are not able to function. Mortal injuries, so injuries that are obviously incompatible with life. Severe full thickness burns covering large areas of the total body surface area. These patients are marked with a black tag. They are palliative care with pain relief. Each of these holding areas will have nurses and medics staffing them and making rounds on the patients. On the following slides, we'll review each one more fully as the patient moves from triage into treatment, meaning that they receive their tag and move to that holding area. So for the green tagged patients, these are often again referred to as the walking wounded. In the case on this screen, those labeled green would then be ushered into the green holding area where they would await care after those more urgently injured are seen. A nurse or a medic will continue to round on these victims to ensure that their status hasn't worsened, in which case they would need to be upgraded. I've listed here some of the injuries that might see and some of the duties that nurses in this area might be doing. So just maintaining basic hemostasis on these victims. Basic prevention of hypo or hyperthermia. Often we have the silver blankets with us that are that hold in the heat so that when a patient starts to go into shock, it helps with that, or if there's severe weather conditions. Basic wound care. So we want to treat them quickly and discharge them if possible. So we will clean any wounds that they have. If we are able, we will provide tetanus and antibiotic therapy, dress any wounds that they have according to where they're going to be discharging. So if a patient has a wound on their foot and they're going to be walking away from the green area, going back home or wherever, then that person is going to need something that they can walk on if possible without soiling it. Send for debridement if needed, and then provide pain. And if you're sending for debridement, that may be something that you have to do at a later time. If it's a small wound or a small burn in an area, as long as there's no sign of sepsis setting in, it may be that that patient is going to sit there in that green area until you're able to provide transport for them. Or if there's someone available to take them, then that person may take them and they can call for follow-up treatment. Sprains and simple fractures. The usual first aid for that is just elevate and immobilize the area and then apply ice and administer an analgesic such as ibuprofen or acetaminophen. Red tags. The red tagged individuals are the ones that we spend the most time with. These are the ones that will likely survive if given immediate, simple, life-saving assistance. So first you see burns. These patients will be triaged. They'll be given IV fluid resuscitation if there's more than 10% total body surface area involved. And I will show you on another slide another way to look at burns and determine how extensive they are, and provide analgesia again if available. Spinal cord injuries. So those people that are suspected to have a spinal cord injury, you want to assess them without turning them as much as possible. Get them onto a stretcher or something by using a log roll. Put something around the neck in order to keep it stable so they're not moving that. And if possible, try to keep someone with them so that if the patient becomes anxious, they don't start to move around and injure themselves worse. Bleeding. If there's an arterial or bleed or a hemorrhage, you want to put pressure on that area and get them immediately transported. So you'll put pressure on, put a pressure dressing there. If there is debris in the wound, don't try to remove it. If it's a deep wound, just send them on. Apply that pressure dressing. If there are signs of shock, then elevate their legs. If there's head trauma, apply firm pressure if there is bleeding, unless you suspect a skull fracture. If there's an indentation, like the skull might be fractured, or if you see pulsating, then you do not want to apply pressure. Lie the patient down with the head and shoulders elevated so that there's not more pressure in that area, and do not move their neck. For inhalation or heat injuries, they can cause massive swelling in the upper airway, and sometimes that will develop quickly, sometimes it will develop over hours. And so these patients need a red tag and should be transported immediately as well. The yellow tag is for those with more minor injuries, and some examples are listed here. There are many, many more. The yellow tag follows the mnemonic RPM 32 can do. So R is for respiration rate, and the 30 is that the respirations should be less than 30. The P is for perfusion, and that means that the capillary refill should be less than 2. And then the M is for mentation. So they can follow mentation. So respirations, pulse, mentation, 32 can do. And so that's helpful to remember for the yellow tag individuals. They should live even if they have a delay of a few hours or longer to receive their care. If the patient has a first-degree burn, then you're going to follow the C's of burn care, and that is cool, clean, cover, and comfort. So you're going to cool it with tap water if it's available, or saline, and then you're going to clean the area gently with mild soap and water or a mild antibacterial wash. Do not pop any of the blisters, and then cover it gently with an antibiotic ointment or cream, and then put on a non-stick sterile dressing. Then for comfort, give them acetaminophen or pain for pain and inflammation. Okay, so I said I would go a little bit further into assessment of burns. So for the extent of burns, there is a chart by Lund and Browder. That's the gold standard because it's accurate regardless of whether it's an adult or a child. It's used only for partial and full thickness burns. Superficial burns are treated just as superficial burns, and they get the 3 C's like I said before, and those patients are green tagged. An example of that would be a sunburn. It's going to look like a sunburn. The burn assessment coverage, though, if you see here, the arms are 10%, the trunk anterior is 13%, and so on. And you have the people with the little markers on them, and it talks about the body percentage for whether it's an adult or a child and at what age. So that's helpful if you really need to assess how much of the body surface is involved. As far as the degree of the burn, first degree, again, is superficial, like a sunburn. It's painful, but it's only the epidermis. There's redness. It's soft, and there's not usually any blistering there. The second degree burn is partial thickness. It's also painful. It's very painful. It involves the epidermis and the dermis. There are often blisters. The skin is red. It's often moist, and it will blanch if you touch it, as will first degree. The third degree burn is a full thickness burn. There is no pain generally involved in this because they have burned through those pain centers. It is into the subcutaneous fat or even deeper, and this usually looks white or brown or sometimes charred. It will feel firm and leathery, and there is no blanching. And when I say it will feel, I'm not encouraging you to touch it with your hands. Sometimes you can look at it and see that there is a leathery look to it. So treatment, again, you're going to run the cool water, not cold, clean it with the mild soap or antibacterial wash, apply the antibacterial or some type of moisturizer, nothing with any dyes or perfumes. Wrap it loosely with a non-stick and a sterile gauze, and then take the analgesics. Do not apply ice. Do not pop the blisters. Don't use any type of food product. No chemicals. Don't apply ointments. Don't go back into the sun with it. Black tag. The final category and the most difficult one is the black tag. This tag is meant not only for those who are already deceased, but again also for those who have injuries that are so extensive that they will require more resources or more personnel than what are available, and or more time than what's available. So that if you were to take time to work on this patient, then many other people may go without care and their condition may worsen. The decision must be made so that as many lives can be saved as possible. These patients are not just written off. While they are tagged black, they are also given analgesia and, if possible, a narcotic, and the nurse or the medic will round on them constantly and try to make sure that they're as comfortable as possible. Sometimes these patients will live in the end and be transported to an acute facility. Using the black tag raises the question of medical and nursing ethics for some. The quotation here is from the World Medical Association, and they stated that it's unethical for a provider to continue to try to maintain the life of one patient who is beyond hope while wasting resources needed for others who can survive. This quote is old, but it is not outdated. It holds as true today as it did in 2010. The statistics listed here for life versus death over the first minutes and hours are staggering. For this reason, pre-hospital triage is essential in trauma situations. If triage is not efficient, missing key symptoms and signs in patients risks lives, whereas transporting patients who do not require acute care results in system strain. There is clear ethical conflict between beneficence and non-maleficence in triage. Careful triage of trauma patients is crucial for optimal outcomes in patients. Mortality and morbidity can be reduced through effective triage, through tagging appropriately, and transport of critically injured patients to appropriate hospitals. Moving into decontamination. If we have a chemical spill or a gas that's been released or something like that where the patients need to have decontamination, and sometimes this is like a barn fire where some of the chemicals that they use on the fields have exploded and are in the air, and the people who have responded as well as the people who were there need to be decontaminated. So prior to moving into the first aid site, the shelter site, or being transported to acute care, victims need to be decontaminated. The protocol is that anyone who has a suspected contamination disrobes and immediately undergoes decontamination process with any available absorbent material and a source of water. If water is not available, dry decontamination with cloths can be used. And then once fire and rescue arrives on the scene with decontamination tents and hoses, the person will go through an official decontamination using water and actively washing using cloths for the best results. PPE, donning and doffing PPE. I'm not going to read through this for you, but just review the methods of properly putting on and taking off PPE, because when you're in an area where there's a chemical spill or some sort of gas in the air, it's vital that you do this in the correct order to avoid inhaling any contaminants yourself. Communication. Communication is also a key part of disaster response. There is internal communication where team members need to have daily pre-treatment briefings and end-of-day debriefings, and sometimes they need assistance throughout the day and they need to speak back and forth. There needs to be some method for them to communicate, whether it's radios or cell phones or whatever. External communication from facility to facility. So the person in charge may need to call into the person where the people where they're transporting to give a report on something, or give report to the people who are coming to transport. Those are external types of communication. As far as external communication with family and other areas, this is to be kept to a minimum, particularly during the time that you're in the disaster area. There should be as little to no communication between the disaster responders and the outside, as it clogs the airways, number one, and also because their full attention is needed for the disaster scene. Security and safety needs to be ensured for all members of the team and for the victims of the disaster. Coordination with government and local and public agencies should occur prior to and at every level of the disaster response. Documentation. There should be patient intake forms, and those should be well defined at the start and the end, so that the form travels with the patient throughout triage and treatment and are collected at the end, so that there is a record of everything that occurred with that patient. Public relations. There's one person in a team who is designated to speak with officials or media if they should come on scene. And this should involve as little time as possible. The people, the personnel who are at the site are designated to be there for a reason, and so Only one person should be speaking with them. And then again, debriefing at the end of the disaster so that people who have responded can talk about things that they saw and recapture some of their feelings about what happened. And some team members, after particularly devastating disasters, are going to need counseling upon return to their homes. And sometimes that's extensive counseling that goes on for a long period of time. In summary, at every disaster, there will be a different scene. Each disaster is a little different. The people who respond to it are different. The injuries will be different, and the treatments will differ. It's a great thing to be willing to assist others in times of great need, but going in with no training can be worse than not going at all. An untrained team member can jeopardize the flow of the team's work, can endanger the relations between the teams and the population that they're serving, and can decrease the effectiveness of the team in meeting their outcomes. A nurse who is trained in disaster response has the ability to plant themselves in the middle of the chaos of a disaster and practice the art and the science of nursing. And they require not only the desire to help, but also training to be effective in less than optimal circumstances. With the increasing number of people who are touched by disaster and assisted by disaster nurses, anything other than best practice to intervene on their behalf is a disservice. The objective of this training is to prepare nurses for disaster response, thereby improving the quality of care that's provided by disaster response teams. To end, I want to share with you this quote from Petra Nemkova. She was a 25-year-old supermodel on vacation in Thailand with her boyfriend when a tsunami hit. Her boyfriend was swept away by the waters and killed, and she was left with devastating injuries that were life-threatening when she was rescued after clinging to a tree for 8 hours. After long months and years of recuperating and rebuilding her life, she went on to partner an organization called All Hands and Hearts. It's an organization that meets immediate and long-term needs of survivors of natural disaster. Her quote is, "We cannot stop natural disasters, but we can arm ourselves with knowledge, so many lives wouldn't have to be lost if there was enough disaster preparedness." Her quote is so true, and I would add that effective and continuous training is what makes us the best nurses, and this is true in disaster response nursing, just as it is in any other nursing field. So now, are you prepared? Now that you've completed this training, please take the short post-test at this link. Once all responses have been received, a drawing will be held, and 4 lucky participants will receive an Amazon gift card as a thank you for participating. But now I thank you all for your responses and for participating in this project that I am pursuing, and I hope that you have learned something valuable to help you in your future of disaster nursing. Thank you.